All right. Now I'd like to introduce our next speaker, Alison Sterite. After receiving her doctorate in physical therapy from Northwestern, Alison, who also goes by Allie, found herself drawn to a complex puzzle of the human brain. So she pursued a career in neurological PT, practicing in Chicago, Boston, and now LA. Allie has spent her 9-year career facilitating the care and recovery for patients with various neurological conditions. And Allie's goal is to help her patients move again in the face of functional limitations. She currently is the lead physical therapist for the CMT and Muscular Dystrophy Interdisciplinary Clinic at Cedars-Sinai. And in addition to working full-time in the outpatient neurological rehab unit. So you're quite busy. So thanks for being with us today, Allie.
All right. So like Nicole said, I work with an adult neurological population typically in my job as a physical therapist. So I treat a variety of neurological conditions, as well as general deconditioning, balance issues, vestibular problems like vertigo, and then sometimes secondary orthopedic conditions that come up with my neurological patients. At Cedars, we have these specialty clinics that are 1 day a week where we the physical therapy, occupational therapy, speech therapy work alongside the neurologist to best address patients who have needs in all these areas. So I lead the MDA clinic, which is kind of, we see a lot of CMT, but then we also see other diseases in the MDA kind of umbrella. And then we actually have a specialty ALS clinic. So I did want to mention just that I am not the lead therapist for the ALS clinic. I'll be able to answer some questions as they come up, but it is such a specialty as well. So here we go. So one of the things I just want to start off mentioning is that, this talk is tough because it's such a wide variety of diagnoses could be sitting here listening to me right now. If we think about all the different diagnoses that fall under this MDA umbrella, we see we have over 50 diagnoses in these different categories. So what that means is that no single recommendation I make will fit every patient with an MDA diagnosis. A big thing I'm going to say over and over is consult your doctor, consult a physical therapist, and kind of listen to your body. Not everything is appropriate for everyone, and I'm going to try to kind of touch on that as well. So just some examples of, like I said, things that I tend to see. My colleague sees most of our ALS patients. We see a lot of myopathies in our clinic where some myopathies respond pretty well to treatments, and we can think about, our physical therapy as like restoring function, while other myopathies don't really, respond to medical treatment, and we need to think more compensatory. Charcot-Marie tooth is something that I see a lot of, just if you have specific questions. And then, mitochondrial diseases. With that, we tend to, our focus may be more on energy conservation and pacing strategies. So overall, this talk cannot speak directly to all of these at the same time. So I'm going to try to speak a little more generally. During the question section, please let me know if you have something more specific to your diagnosis. I can answer on a one-to-one basis. And if I can answer on the fly, I will. Otherwise, I can get back to you later today or at a future date. And you can always provide Nicole with your email, and then I can kind of write up some responses and get back to you. All right. So the role of physical therapy in neuromuscular diseases is kind of to maximize your functional ability and to minimize other secondary complications. So that, I typically am going to ask patients about their mobility level, how much they're able to move and do on their own, what they need assistance with in terms of maybe bed mobility, transferring from a seated to a standing position or out of bed, balance in sitting, balance in standing, and getting around. Maybe that's walking, maybe that's using a wheelchair, or they need some equipment. And then, a big part of today's talk is this minimizing secondary complications. We want to get people as active as possible and maintain as active as possible of a lifestyle in order to prevent these secondary complications. Pain, arthritis, weight gain, postural changes, disuse atrophy, falls, all of that. So, ideally, my goal is to optimize your independence, safety, and well-being, which then comes across as an enhanced quality of life. So, in our multidisciplinary clinic, just in case you have one in your area, what to kind of expect. As a physical therapist, I come in and do kind of a quick consultation and evaluation. So I'm gonna talk to you about your mobility skills, assess your strength, assess your flexibility as much as I can, look at your balance. And after assessing each part of you, I ask lots and lots of questions about, your day-to-day routine. After assessing that basic part of you, I typically am going to establish some sort of home exercise program. Because as I talk later, getting some sort of home routine in is really important to maintain functional abilities and activity and prevent a lot of these other things from coming up. And then I also make recommendations. So sometimes my recommendations are to follow with a formal physical therapist, maybe somebody to come to your house, maybe in an outpatient setting. Sometimes I'm going to recommend a home safety evaluation for someone to come out and assess your home for, can we make any of this safer? Recommend assisted devices and equipment, and then also provide some supportive and educational resources that apply to kind of what I do. So if we think about who needs PT, typically, we're going to look at all these things in this circle based on your diagnosis, based on your ability levels and where you are functioning right now. Maybe walking is not something you're doing. Maybe transferring is not something you're doing. But we want to say, do you have a home program? Do you have an exercise program? Whether that's passive or active. If you don't and you need guidance, seeking PT is a great idea to learn a program and then implement it on your own. Other reasons you might seek PT are just you're noticing new declines, worsening tightness in muscles, increase in falls, injuries, worsening posture, all these things. A lot of times also a physical therapist can trial equipment with you if you think it's time. Okay, I've been using a cane, but I'm just not super stable with it anymore. I think I need to upgrade, trying some things out and seeing what a recommendation would be. And then also sometimes we just are doing caregiver training, teaching people how to do pressure relieves to reduce risks of skin breakdown and addressing all sorts of things. So physical therapy covers a wide range. It's not just what some people would think of as like, I've had a joint replaced and I need to see a physical therapist. So there are a lot of different types of PT, and that's just kind of, I want to give you guys my background so you know where my recommendations are coming from. So the last little piece about this physical therapy is that we're going to look at you as an individual and kind of take joint by joint by joint and say, what is an appropriate home exercise program for you? Some diseases spare certain muscle groups. Sometimes you have no involvement in your lower body, but your upper body is really involved. So in those cases, we can exercise those muscles that are least involved the most. And then, we're typically not going to be exercising in a strength way the muscles that are more heavily affected. We're typically going to help you develop kind of compensatory strategies for those majorly heavily affected muscles that you may have related to your disease. Okay, so our big topic today is physical activity, and it's just movement. It's just getting people moving more, which could be anything. So the four kind of main components of physical activity are going to be strength, flexibility, balance, and endurance. So throughout my talk, I'm going to kind of talk about all of those categories. But in terms of creating a home exercise program, what I want you to think about is trying to do each piece of those in terms of your home program. If you're only addressing one of those, then your program might not be as complete as it could be. So why should I be physically active? Basically, we can't exercise away neuromuscle disease. So there are still reasons we should exercise because we can try to prevent these other complications from coming in. These other complications can be what worsens our quality of life and our overall health. So if you see, we have some, statistics that increasing your physical activity can reduce other chronic conditions such as heart disease, diabetes, cancer. It also shows some protective benefits for cognition as we age, which is a really great big one. And I mean, I want you all to think about what we've been living with COVID-19 over the last year. Most of the people who had, severe cases and death in some situations had a lot of these comorbidities, we're going to call them, diabetes, obesity, heart disease, edema. So by being physically active, we can try to reduce these other diseases and, help with our overall health. Additionally, things like contractures, which is tightening and really getting stiff through joints, maybe from immobility or being unable to stand or move in certain ways. Being active, stretching, doing these things can reduce our contracture risk. It can reduce a contracture if you have one. Additionally, a wound and potential for skin breakdown. We want to keep blood flowing throughout the body, which is delivering your skin nutrients, which helps wounds heal and prevent wounds in the first place. So in general, we can't change the disease, but we want to slow the progression of the factors that might impact your function. And so sometimes the cardiovascular conditioning is the easiest thing to get started with because this can be any activity that brings your heart rate up. So like we said earlier, there's these four different components of physical activity we want to talk about. Most of the exercise of the recommendations, across the board, generally find that moderate intensity exercise or activity is not harmful in the face of neuromuscle disease. That also includes low intensity, which is fine. High intensity exercise, we are a little more worried about. To be honest though, there is not a ton of research out there. So generally we're, as a therapist, I'm going to teach you guys about what moderate intensity exercise is today, just to give you guys that background. So the things we want to look at first are what's appropriate based on your current level of function, okay? And what's appropriate based on your diagnosis, and then how do I get started, okay? So like I said, cardiovascular conditioning is sometimes the easiest thing to get started with. I have a couple examples of home equipment that people might have or get, a recumbent bike or a tabletop bike. Sometimes these tabletop bikes can be used either on a table or on the floor as like a pedaling device. Other examples could include just a seated stepper, an upright bike, an elliptical. But getting your cardiovascular exercise could be as simple as walking in your home. It could be walking in your community, walking stairs, or pushing a wheelchair. You can get anything that elevates the heart rate. Some people enjoy exercising more in a community setting, walking in a park, swimming at a local pool, or joining a health club. Things are starting to reopen, so I can mention these things again. I'll say that for the last year, a lot of my patients now are coming to me deconditioned because their access to a lot of these types of activities was really limited over the last year. So you may find that's you as well. You can also achieve cardiovascular work during other forms of exercise, weight training, body weight movements, anything that elevates the heart rate. So in general, the World Health Organization recommends 150 minutes per week of moderate intensity exercise. With that said, that is not necessarily appropriate for everyone. If you are not very active at this time, this is not like your short-term goal to start with. We do want to talk about how to set kind of a realistic goal based on what you're doing right now. So, that's why we're going to talk about activity trackers later in wearable technology. Finding out what your baseline is, finding out what your typical day-to-day movement is a great place to start, so we can set kind of the short-term goal and then maybe a long-term goal of reaching this World Health Organization recommendation. All right, because we want to make sure our goals are scientific and realistic based on your condition. And so again, some of this might not apply to everybody. So what is moderate intensity exercise? This is one scale that we use with patients. This is more of a subjective scale, like how do I feel? It is a rate of your perceived exertion. So if we think of 0 to 10, with 0 being no exertion at all, and 10 being your maximal effort activity, we consider moderate intensity exercise in the 4 to 6 range. So in this range, you want to think that your breathing kind of quickens, but you're not out of breath. And then, at this level of work, you could have a conversation while you're doing, your activity. But you might not be able to do something a little more effortful like sing. And then if you are rating how hard am I working, you may rate somewhat hard. I'm not working hard yet, but I'm working somewhat hard. I'm on my way. You can see the rest of the scale and kind of at those higher intensities, those vigorous activities, that's right now where we're not trying to focus. We want to focus moderate intensity. And like I said, you can always be lower intensity than that as well. So the more formal way to assess what moderate intensity exercise is would be to track your heart rate. So I have a little information on here about how to check your heart rate using your pulse, which doesn't require additional equipment. It just requires locating your pulse at your wrist and doing a little calculation here. So an easier way is to use some sort of activity tracking device like a watch that tells you your heart rate without you having to do any math. Additionally, there are things like a fingertip pulse oximeter, which can also tell you what your pulse is, but those are things that require equipment. So one thing to mention is just that certain medications, specifically beta blockers, can suppress heart rate increases. So you might find that what you rate as your perceived moderate intensity exercise based on exertion, like this 4 to 6 out of 10, may not match with the heart rate range we calculate. So I would tell everyone to be on the safer side to use your perceived feeling of exertion as your go-to to when you first are starting exercise until we're better at looking at the heart rate. So again, there's a calculation that we can use to determine what your safe heart rate range is, and that's based on what your max heart rate is based on your age, and then that's based on what your resting heart rate is. So this slide has an example of kind of how we would do this calculation. I'm going to just tell you all that if you want me to help you calculate your moderate intensity heart rate range, you can, you could send me a message, or we could have everything go to Nicole, but you could send your age. And then if you just would calculate your resting heart rate, I can send you back a range, okay? Again, this range doesn't mean this is the only place you can exercise. We have to see how you respond and how you tolerate it. But this is how you would calculate it. Basically, we are just trying to work within that 40 to 60%, intensity. So that's our calculation here. So here's an example of like the target range for someone. Based on the age and resting heart rate. All right, so the next thing is kind of exercise precautions related to neuromuscular disease. This also goes with just exercise precautions for anyone, but the phrases I'm gonna say are listen to your body, consult your doctor, and consult a physical therapist. If you don't have experience exercising and things like that, it's safer to do that in a more supervised way. So that's going to be my biggest thing. Like I said before, we want to avoid high intensity exercise. At this time, we just want to avoid excessive fatigue and muscle breakdown, because in some of these neuromuscular conditions, our body cannot replace that muscle that we've broken down. And so it's actually more detrimental than it is effective. So again, we're sticking in that moderate intensity range. So things we want to look for it to say, am I over exercising, would be muscle pain, cramping, fasciculations of muscles, which is kind of the muscle spasming. And then fatigue that lasts beyond 30 minutes of rest. So if you've rested for 30 minutes and you're still having a really hard time recovering, you cannot complete the rest of your daily activities, it means you've done too much. It's over fatigued. Then other signs of overexercise that might not be, related to your neuromuscular condition, but joint pain, swelling around a joint, dizziness, lightheadedness. Those are all things that we want to stop exercising. We want to cool down and maybe talk to our doctor or our therapist about changing what we're doing. All right. And then the last thing is just our focus is not to exercise, like strengthen these heavily affected muscle groups. Okay. That's just really the big thing. And that's a big piece of education I need to give people when they come see me, because they pinpoint this muscle group that's very weak from their disease. And they say, what exercises can I do to make this stronger? And unfortunately, that's really not how this works. We need to focus on the unaffected muscles, and preventing disuse atrophy more than addressing these muscles that are weak due to the neuromuscular disease. So something else just to expect from initiating an exercise program is that there's something called delayed onset muscle soreness, which is considered normal. This is, 24 to 48 hours after exercising, feeling muscle soreness. That's a pretty standard thing. If it is so debilitating that you can't function, that you can't do your normal activities, then again, you've done too much. But the 24 to 48 hour range after exercise, it's normal to have some soreness. All right. So here now is kind of an example of how we think about exercise precautions in terms of strengthening. So for patients, I'm going to check, can a patient move through the full range of motion with gravity acting as a resistance? So we have an example over here of shoulder flexion. We see a picture, the guy raising his arm all the way up over his head. So that's full range of motion against gravity. If based on your condition, you can only get your arm halfway up, or you have to kind of fling your whole body to get your arm up, you shouldn't be doing resisted exercise. It's already too challenging for your muscle to just move against gravity. So we do not need to add resistance for you. Instead, maybe we need to move into a gravity reduced position, like lying on your back, lying on your side, a different environment like a pool. and work in that setting. Maybe we need to do active assisted work. So the picture here where someone's using the cane to kind of help them bring an arm up through the motion. And then lastly, sometimes we just need to do more passive work, caregiver assisted movement, or like a tabletop slide where you're just moving the rest of your body to move that joint. So, you know, a lot of times patients with facioscapular humeral dystrophy, FSHD, they want to strengthen their shoulders. They come to me saying, I've been using dumbbells at home, I'm trying to get stronger. However, if they can't move their arm fully against gravity, the use of dumbbells or resistance bands is really not appropriate. The focus for these patients should be on maintaining full passive motion. So, and that's more of a flexibility exercise because that's going to reduce issues related to like contractures in the armpit so that you can perform dressing, hygiene care, so you can get into your armpit, and things in the future. Performing inappropriate exercises based on your condition or your function can really end up leading to more overuse, injuries, and pain. And so again, sometimes people are coming to me with a lot of shoulder pain because they've been trying to exercise when it's not appropriate for them in certain ways. And then lastly, I just want you to think, like maybe you aren't able to move your body independently. Passive exercise where someone else is moving you, provided by a care provider, is still beneficial. One of my kind of phrases that I use in therapy is motion is lotion. Any type of gentle movement, even if it's provided by someone else passively, can help lubricate the joints, which can help with your overall comfort level, and again, kind of carry over into better quality of life, not being in pain. So the other, right, we've talked about cardiovascular, we've talked about strength, and now balance is another component. Balance is controlled by many different systems. It is controlled by our, strength in our lower legs or our feet and ankles. So if you have a peripheral issue and you have a lot of weakness in your feet, we can't change that, right? But so in addition to the strength in the lower leg, it also is controlled by the sensation in the lower leg. It's controlled by our visual system, by our vestibular system, which is our inner ear, and then also our proprioception, which is our proprioception is knowing where our body is within space, and that is controlled in all the muscles and joints of the body. So maybe your proprioception isn't intact in your lower legs, but further up in your legs, in your knees or your hips, it may be more intact. So we can treat balance by addressing a lot of these other categories. We might not be able to fix one or two of them for you, but we can try to address little pieces of it with these other things. So how to train your balance in general is that we want to find something that's challenging for you, but that you're also successful at. We want to work in this challenge zone, but we don't want you to be failing, because you're not going to build that improvement and that success. So, sometimes I'm giving examples for kind of standing balance. Some people are going to do this in a seated position. Some people are going to do this with equipment or standing at a countertop. But basically, we want to think about varying our base of support, which is like how much support our feet are providing us. So thinking wider base is going to be easier, and then narrowing that base is going to be harder. So some people can work through these different positions to get into a harder position and get better balance there. The next thing is we might vary visual input. So maybe let's say you're not able to stand, but we're doing seated work. And doing some things with your eyes closed, turning your head, that's going to train, the vestibular system to work a little bit harder. And then lastly, we can then vary the standing surface or the sitting surface, sitting on something more uneven or standing on a cushion versus standing on a solid, heavy floor. Like someone who wants to be able to walk on a beach needs to be practicing balance on some uneven surface. And then adding an additional activity. So like, what do we need sitting or standing balance for? We need it so when we're sitting and we need to get dressed and we reach and bring our arms over our head and reach down, we need to be able to stay balanced. When we're standing and maybe we're reaching into a cabinet or something like that, that's why we need balance. So we actually incorporate those types of activities into the movements. So again, balance, all of these things. I would consult a physical therapist to help learn what's the best home exercise level for you to be working at. Kind of what's the challenge zone for you. So our last major category of exercise or of physical activity is flexibility. And so here I have a couple different pictures of just 3 different methods, all to stretch kind of the same muscle group. So commonly contracture locations, which means like muscle and joint tightening and shortening, happens a lot at our ankle plantar flexors, which are the toes pointing downward. Okay. Also happens a lot up at the hips into flexion, meaning our legs don't straighten all the way, or our knees into flexion. Our knees don't straighten all the way. So, for example, when I work with my patients who have Charcot-Marie tooth, they're at a high risk of developing foot and ankle deformities, and stretching needs to be kind of vital for these people. Highly, highly, highly recommend daily stretching to prevent onset of contracture and to treat a contracture that's already there. So like we did with the strength, we say, okay, we've got all these different ways to stretch. Maybe we need to do caregiver assisted stretching. Maybe we can do positional stretching, like this person who's standing on a wedge, or maybe we have more body control and we can do a standing active stretch like this man at the wall. So even if you're not ambulatory, even if you can't walk, the positioning of your feet on the floor is really important for transferring. So in order to be able to put your feet down on the floor for someone to be able to transfer you, we need your feet to sit flat as much as possible. So stretching is really important at the ankle for everybody, typically. And usually, just to point out, if you wear braces in your lower leg, you're not going to wear a brace while you stretch, but you are going to wear, if you have an orthotic or, supportive footwear, typically we're going to recommend you wear that because it's going to help balance your foot in the best position. Okay. So now we're moving on to kind of wearable technology and the idea of activity trackers. So, these are devices that can help you determine what your current typical level of function is. How much am I moving day to day? Some people might be moving 300 steps a day, and steps, right? I'm going to put in quotes because it's movement in general. Some people are moving 3,000 steps a day. So we want to find this baseline starting position, and that's going to help us set more short-term goals. If we're not moving as much per day, we might set a weekly goal of increasing our steps like by 50 or by 100. If we're moving more, if we're moving thousands of steps a day, we might be able to set a goal of increasing our weekly, average by 500 or 1,000. These wearable technologies are just another way to help you stay accountable. A lot of times they'll give you reminders throughout the day to move, to stand. They also give you kind of these bursts of dopamine, right? Reward, because you've achieved your goal. And it says, good job, you've achieved your goal, which really does help. It also can connect you to friends, peers who also have the same type of device. So you can, compete with someone else or cheer someone else on for achieving something, which gives a sense of community. The last thing that these wearable technologies can have, which is a cool feature, is they have some safety features now. So there's fall detection technology, as well as heart rate monitoring, which can help you, again, know what range you're exercising in. And if you're working too hard, or if you're having spikes or changes in your heart rate throughout the day. So, you know, different products come with different settings. Out of the box, they may have kind of standard goals, but they can be adjusted. So if, you know, you hear, oh, the healthy thing to do is get 10,000 steps a day, but that's way far from where you are, you can adjust that daily goal, and you can still achieve these daily goals based on where you are. I think I said that's all done. Let's see. So here are just some examples, kind of what's on the market, what's out there. A basic pedometer is a good place to start if you haven't used any sort of tracking. It's just going to kind of give you your step count of the day. They're going to be the least expensive, most basic, just something. A lot of people, because you have a smartphone, have options to just use the activity tracking on your phone if you keep your phone with you throughout the day. And then there are a lot of different brands out there, Fitbit, Samsung, Apple, that have created these more technologically advanced types of activity trackers. To name a couple, the Apple iWatch has added a wheelchair feature to their exercise. So wheelchair users can select the exercise feature, go through, you have to go through again to like different types and find some of the wheelchair ones. But you know, if you're a wheelchair user, there's ways that you can adjust what are you doing as exercise for that. The Fitbit Flex also has a wheelchair movement feature. And then there's a app or a device that's kind of still in development called Freewheel. And that's going to be a device that's specifically for wheelchair users. It does look like it's still going through development when I did a little research on there. So these are some products that have this fall detection technology. Okay, so newer versions of the Apple Watch and the Samsung Watch have a technology that can help detect if you've fallen. So this is great because if you have a fall and you don't have your phone with you or something, the watch can detect this. It can send an alert to you, you know, and if you're responsive, you can click on your watch, you can follow the prompts to kind of tell it, I'm okay, or I need help, or call my emergency contact. The biggest things are you do need to program this ahead of time so it knows who to call and knows, you know, what your settings need to be. If it does not register movement, you know, maybe unfortunately you're unconscious or something like that, it will automatically call emergency services. So it'll give your location, which is great, so they know where to find you, because, you know, some of the biggest issues with falls is being left and staying on the ground for a long time. So these are two awesome features. I wanted to also talk about some products that just have unique features. With different neuromuscular diseases, we might not have as good finger function or dexterity. We might use a walker, and so our arms don't move as much when we walk, and you might want to track your activity in a different way. So the pedometer I showed on the previous screen was a clip-on model. You know, you could clip that to a belt loop. You could clip it to a backpack. It doesn't have to be on, you know, your wrist as you would traditionally think. There are some that have these like pendant or jewelry look that can, you know, you wear around your neck or you wear around your wrist, but it looks a little bit different if that's something you like to, but still give you that activity tracker. There's a ring. There's a couple different companies that make this ring. One's called Aura and one's called Motive. And, you know, these track sleep and activity, and it just stays on your hand, so once you have it on, you keep it there. And then some other features like a clip-on feature, this jawbone style clip-on. And then for walker, this one, it looks like it only works on a 2-wheeled walker, but it's called the AmbuTrack, and it's a pedometer that's attached to the walker, and it kind of tracks how much you're moving and walking a day. So that's great if you're trying to figure out or like increase your daily walk. Specifically, that's a cool piece of technology, and it is on Amazon. All right. So the next thing I want to kind of talk about is, in order to exercise or be more active, you may need to use some sort of adaptive equipment to make you safer. So this chart kind of deals with kind of the foot and ankle. Again, thinking about that person who might have weakness or sensory changes at the foot and ankle, which are keeping them from being able to exercise or stand or be active. Maybe they're fearful of falling. Maybe they can't stand and balance. So using something or getting the right equipment might open up the opportunity for you to be more active. So, you know, it goes from an orthotic device, which sits inside your shoe, to maybe someone wants to do like yoga or Pilates, which, you know, they're used to doing barefoot. Wearing something, just a light stabilizer or a gauntlet style ankle brace is going to give you more stability, more joint protection. And then, you know, that can advance all the way to an AFO, an ankle foot orthosis, which comes in many styles, many varieties, but may help you then be more balanced in standing or walk more, use less energy because you're more stable. So not all braces are created equally, I like to say. Maybe in the past you tried a brace and you didn't like it. Consider looking again. You know, AFOs are this supportive ankle brace that kind of goes from usually right below the knee and then into the shoe. Some braces are made more rigid, which can help with people who have less natural stability. Maybe they have more weakness in their calf muscle. And some braces are just meant to help achieve a heel strike or lift your toes when you walk, so you're not tripping. But again, with all of these, we think of, if a brace now allows you to be more independent and safe, it's going to open you up to doing more. So I like to say, if you are restricting activity because you're fearful of falling or you're not successful with walking or mobility, see if adding a brace or an assisted device can then allow you to be more active. So this chart kind of just shows some different examples of assisted devices that I may trial with a patient depending on their presentation. You know, we have a cane. Some canes are even collapsible, so they can easily be put into your bag. Trekking poles, you could use one, you could use two. Different styles of walkers we have here, which again are going to be appropriate for different levels of mobility. But if you think about using a mobility aid for longer distances or more demanding tasks, it may allow you to you know, conserve more energy so that later on you have more energy to complete your daily routine. Instead of working so hard to walk or focusing so hard on your mobility that then you get home and you have no energy to do anything else the rest of the day. So the last thing I want to just touch on is, you know, if you are not mobile anymore, none of these assistive devices are working for you, it's maybe time, or maybe you're already in a wheelchair, but the process of obtaining a custom wheelchair, okay, is something that a physical therapist can also help you with. There are different kind of groups of chairs. So if you are considering, you know, your first chair or something like that, and you think you just want to do a scooter or a basic power chair, those are group 1 and 2. And for those, you do not need that much. You just need a prescription from your doctor, and you need to work with a durable medical equipment vendor to get that. A scooter is a basic seating. It doesn't provide extra stability or skin protection. It doesn't have power function. When we get to the group 3, that's a more custom device, and that requires a face-to-face appointment with your physician, a wheelchair evaluation by a physical therapist, some states that's an occupational therapist, and meeting with an ATP, an advanced technology professional who helps take your measurements, assess your home, and make very specific recommendations. So I just wanted to mention this because if you are considering a power chair or something, or a customized chair, the process does take some time. It can take about 90 days. So these are the steps that we need you to, get the process started on. And then, with Medicare, and then most of the other insurances, there is this kind of 5-year rule. So if you get a wheelchair, that chair, you don't qualify for another wheelchair through your insurance for the next 5 years. So that was a quick talk on all sorts of functional physical activity. And now it's time for questions. And like I said before, if you have really specific questions to your diagnosis, it may be easier for me to talk to you directly or answer you directly. I may be able to answer some of these on the fly. I might need time to consult like the different diagnoses with these. But I can always reply via email if it doesn't work now. So that's it. Thanks for listening.
Thanks, Allie. We have a person that typed in, and I know this is obviously not normal, but I wanted to get your take on it. She's got limb-girdle, and she notices when she does a little bit of exercise from like sit to stand and maybe do 5 reps, she gets nauseous. What advice would you have for her?
I would say I don't want you to be nauseous, right? So we want to think about what could possibly be happening. You are changing your position of your body. You're kind of moving quickly through planes, which could be a blood pressure change because, the blood is rapidly moving from different parts of the body. Sometimes nausea is linked to vestibular issues as well. I would say that the intensity of the exercise may just be a little bit too much as well. It's hard for me to pinpoint exactly, but those are the types of things I would look at. I don't know if you check your blood pressure at home, but some people will check their blood pressure in a seated position and then check their blood pressure in standing. And if you have a certain amount of drop, I would have to get the specific numbers, but you might be considered orthostatic hypotensive, which means your blood pressure drops when you have a position change.
Perfect. Thank you. This person is on several heart medications due to 100% blockage in their LAD, and so they cannot raise their heart rate. How does a person in the situation tell if they're getting any benefit from the cardio that they are doing?
This again, I would say, is where you use that like perceived exertion to determine how you're doing. Do you feel like you're working somewhat hard? Do you feel like you're getting a little bit short of breath? That you kind of use that 0 to 10 scale, aiming for that 4 to 6 intensity. That's what I would say. But again, anything is better than nothing. So I would say, even if you don't feel like you're able to push yourself to that because of the medication you're on, still beneficial to do something. Okay.
Perfect. This person has FSHD and has seen a physical therapist over the past few years. Their question is about stretching. They were told not to overdo it and not to do it with their legs straight. So how much and when and how often do you incorporate stretching into a PT routine?
So again, it kind of depends on your individual case and why your therapist told you, we don't want to overstretch if you don't have a lot of muscle control at certain parts of the motion. When your arm gets over your head, you might not be able to control it to bring it back the other way. So I would say that your therapist should guide you in what specific stretches you should be doing, and listen to their recommendations. In terms of, again, we have the 150 minutes a week is the World Health Organization goal time. So I recommend kind of mixing up the routine. Maybe your condition needs flexibility every day, like someone who has contractures, but maybe you need to be doing flexibility 3 times a week and doing cardio or some other balance exercises the remaining days of the week. Again, it's super individualized, so it's a little bit hard for me to answer.
Okay. How does one find a PT that has relevant knowledge and experience with neuromuscular disease?
So this can be tough, and I would say that don't, judge the one PT you've seen for all the PTs. I would say it's kind of something you have to shop around for, but looking in your area or like looking up on, Google, neurological physical therapy and finding clinics that specialize in that, which I'll say at least, one of my go-tos is to look for a hospital in the area. The hospital outpatient department is typically going to have some sort of neuro program, especially somewhere that has an inpatient rehab, because that's going to be, a lot of patients who had strokes or major issues happening. So then those patients come as an outpatient. But Googling a neurological physical therapist, and then you may find you don't mesh with one and you want to try another one, and it happens. That is a tricky thing. If you are involved in a MDA, interdisciplinary clinic in your area, you can see if they have recommendations for local therapists as well.
Perfect.
That's how a lot of my patients find me.
Okay, perfect. And I want to close with this last question to see if you could comment on that. And obviously, not everyone, their insurance is a little bit different when it comes to PT and how often they can go and how long they can go for. So do you have any recommendations for ways to essentially mimic a physical therapy, but possibly with a helper at home, so you can continue maintain a more realistic regime when you're at home?
Yeah, so physical therapy is not meant to be like permanent year long. We typically think about doing it in episodes, okay? Coming to PT, your goals may be caregiver training, maybe mobility training, and designing a home program. Once you've designed the home program, and where I work, I like to teach the caregivers. I have them bring their caregiver in, teach them through the routine, and then they go home and implement that. If you're noticing that the routine is no longer feasible, you're changing your function, or maybe the routine is too easy, that's then a time to go back to PT, later in the year. So I might see a patient for 6 or 8 visits, and then they work on their own for 6 months, sometimes 3 months, sometimes a year and a half, who knows. And then they come back to me and we update the program or we address new needs. And then we kind of think of it as an episode. So I see you once, then I see you again, and then I see you again. So now I've been at Cedars for 4 years. So I have people that I see every year for sure, and sometimes multiple times a year, but just a little bit at a time. So it helps with the insurance benefits.
That's great. Thank you for explaining that.
Yeah.
And we are up for time, and I believe we got to all of our questions. So thank you very much for your time today, Allie. Have a great rest of your Saturday.